we tend to see a lot of diffusely diseased vessels. So number one, I think we cannot compare our mortality figures with the STS database or with the European databases. So this complies us with the importance of having our own standard database, which is also one of the topics of the society meetings as well. So we can compare our data or the data of any individual surgeons with our own population, number one. Secondly, I think that because we are seeing a lot of early cabbages in our own population, means people, they do come for cabbage even at the age of 25 years, 30 years, 35 years, which we are facing. So we need to tend to use more of the arterial grafts, I think, in those patients. We need to more use the IMAs, bilateral IMAs, and the radial arteries. So this is what I would like to suggest.
Professor Shankar.
Thank you, Tariq. I think, we all agree that in our part of the world we see our patients much younger. I think we are dealing with two different subsets of disease. I think in younger population we see more inflammatory coronary artery disease as compared to the older group of people up to the age of 60, where you see a normal wear and tear atherosclerotic coronary artery disease. I think in younger patients, each patient should have an individualized plan of treatment. The goal should be that he should be able to achieve his normal lifespan. We know that the younger patients will have much more higher risk factors. They have more diffuse disease, and almost invariably all the coronary arteries are involved in these patients. And my philosophy is to be able to drag on their treatment and to be able to achieve these patients reaching their normal lifespan. I think a good combination could be that initially these younger patients should have an interventional cardiological treatment. Stents could be put into these patients and try to delay the coronary artery surgery as long as possible, so that when they do come for the coronary artery surgery, they probably, they should be in their 50s or maybe 60s, and then coronary artery surgery will take them to their normal lifespan. I think at the end of the day, we are looking at the end stage of the disease, the burnt-out disease. The way to go is to prevent. All these patients have very well-known, and these patients have high-risk factors: diabetes, history of family disease, hypercholesterolemia, hypertension. And I think this is where I think the future is to prevent coronary artery disease. We are only looking at the end stage of the disease, the burnt-out disease. And I think if you look at all the trends in USA and in North America, the emphasis now is on the prevention. So I mean, this is what it should be, and I think these younger patients, it's a very difficult and challenging situation, and I think you have to tailor their treatment according to that particular patient. Thank you.
Dr. Saurabh.
So thank you, Tariq. The answer to your question is our population is extremely different. We have far more diffuse disease. We have smaller vessels. The IMA size is small as compared to Caucasians. The Afghanis do have bigger arteries, the Afghan population. But our population, especially the south of Pakistan, have very small arteries. And we have diffuse disease. But you have to have a standard. So right now we don't have a standard, so we do compare our results with the STS database. So especially in our centers, in the center where I work at AKU, we do compare our results, and it should be comparable or close to the STS. Now you're not comparing somebody with the 20% EF with the same result as somebody with an EF of 55%. So you're looking at apples and oranges. You want to compare the results with STs. In AKU, we do compare with them, and I can tell you that our results are, alhamdulillah, pretty comparable. As far as the training of the residents are concerned in Pakistan about off pumps and all of this, we hardly do any off pumps in AKU. We quit doing them in, like, not many, we only do them very few, since 2009, about after the NEJM study, where they clearly proved one result over the other. Now, we can argue about this for a long time, but that's the data we look at in NEJM in 2009. Everybody can look it up. So we decided it's not saving.
As Dr. Pasha mentioned, about 40-50% of my patients have multi-arterial grafting, so I always use radial artery. My leg vein is never beyond the knee joint, the leg vein harvest wound. And I've seen that if you can do that, then the wound-related complications are minimal. And the days have gone really of an incision from the Adam's apple to the navel. You can do a 5-inch, 5.5-inch incision and do a little bit of undermining on both sides and do a full sternotomy for conventional limited old-time surgeons and do a proper full revascularization with good sexy-looking incisions and no wound complications. Thank you.
Thank you, sir. So with this, we move on to the next session, and I would request Dr. Shahid Sami to be part of the panelists for that. And the same panelists remain seated over there. We're not having any change of panelists. Just Dr. Sami is joining because one of the panelists is a speaker in the same session, in the next session actually. So moving on to the next thing is TAVR versus SAVR or SAVR in young or low risk to intermediate risk patients, the pros and cons in our population. And I would like to invite Dr. Waleed for the presentation on behalf of the cardiology, and he has been he has specialized in structural heart interventional cardiology, currently working as assistant professor at Peshawar Institute of Cardiology. Dr. Waleed.
Thank you so much. Thank you, organizers. Thank you, PACVTS, for giving me the opportunity to talk and defend and present about the TAVI or TAVR here in the presence of lords and lords of surgeons. I would like to, yes, this one, please. Can I see my presentation? So that is how you guys treat a cardiologist? Not even putting his presentation here. दूसरा कौन था? नहीं, सावर कभी मैं ही करता हूँ। Okay, good. So I'll briefly talk about the evidence behind the TAVI and the comparison of the complications with the TAVI versus SAVR procedures. And then there is usually a question about the durability of the TAVI valve and what's the effective orifice area and the mean gradients. And then at the end we will talk about the guidelines, international guidelines, and how much are they applicable here in Pakistan. So just briefly, it's a transcatheter aortic valve implantation, and in majority of cases is done through transfemoral access. But the alternative access we use are the subclavian, transcaval, and previously they were using transapical and transthoracic.